Alright, so to start, we're going to wash our hands and then just ask our patients if they have any allergies and then anything that they want to assess first, any concerning factors. We've already established that this is just a normal assessment, so we'll just go ahead and start. So to begin, I'm going to ask my patient to identify her name, the date, and the location.
Nicole Overdorfer, 11/29/2016, Kansas City, Missouri.
So we're noting that the patient is alert and oriented ×3. She doesn't seem to be in any acute distress. She seems comfortable, an appropriate level of consciousness, appropriate mood, appropriately dressed. So we'll go ahead and just start with the skin assessment. So we're just going to evaluate the skin color first, just noting that it's all evenly colored, it's consistent with her genetic background, there's no hyperpigmentation, hypopigmentation as we go through. So as we're going to go down, we're going to use the back of our hands to palpate the temperature. We're just going to go on both sides, just feeling, and you're really just noting that it's the same on both sides. If it gets a little cooler on the feet, that's normal as well since it's an extremity. We're just noting that it's equal on both sides. Also, as we go down, we're just looking for lesions. If any lesions were noted at this point, then you would want to identify those characteristics. The size and diameter in centimeters, location, shape, if there's any elevation, any exudate, anything like that. So as we go down, we can also do edema while we're here. So we're just going to put some pressure on her foot, also on the ankle, and we're going to see if that indentation is left there. It's not, and it returns back to normal, which is good. That means there's no edema. But if there was pitting edema, you would want to grade that, and that's just seen with that indentation from the pressure left for a few seconds. So then we'll do the skin turgor. So we're going to pinch an amount of skin right under the clavicle. And you see that right away it returns to normal. That's an indication of good turgor. It means that the patient is well hydrated. If the skin stayed up for a moment or didn't quite go back, that would be an indication of dehydration. We would want to further assess. So moving on, then we'll just go ahead and do the face and head. So first we're just going to feel the scalp. We're looking for it to be normal cephalic, which just means that it's round, symmetrical, there's no lumps, no deformities. Also, while we're here, we're going to check for the hair distribution, just making sure that it's distributed evenly, the texture of the hair. At this point, you could ask if they've experienced any hair loss, which our patient hasn't. We noted that they don't have tenderness while we're palpating. There's no lesions, so these are all normal findings. So moving on to the face, we're going to test that facial nerve. So this is cranial nerve 7. We're going to ask her to do a series of movements, just smiling, frowning, raising her eyebrows, or puffing out her cheeks. So as she does some of these, we're just noting that both sides are moving symmetrically. One side isn't lagging, so these are all good findings. Lets us know that that cranial nerve is intact. As we observe the face, we're just noting that the features are all symmetrical as well, that they're all in line with each other. That's just a good indication to see from the beginning. So then we're going to palpate that temporal artery around that zygomatic bone. So this should be palpable, and you just want to check that it's palpable equally on both sides. We would do this as a grade 2, symmetrically and bilaterally, which is good. So as we're moving down, we can do that TMJ joint right there. So as I press down on the patient, I'm just kind of seeing that it's moving well, that she doesn't have any limitations or tenderness or any crepitation. So as I'm feeling there, I'm going to have her move her jaw up and down, side to side, or protrude it. Just knowing that she doesn't have any limitation, which is a normal finding. So then to assess that trigeminal nerve, I'm going to have the patient clench their jaw or teeth. And as they're doing this, I'm just feeling that it's symmetrical, and then I'm going to try to test the strength by pulling down on her chin. Since she's able to resist that pressure, that lets us know that that nerve is intact as well. Okay, so now moving on to the eyes. We are going to test that optic nerve 2 in the near vision with a distance chart. So I'm going to stand about 14 inches away, and I'm going to have the patient cover one eye and read the furthest line she can from that. So we'll start with covering the right eye.
937 826.
Okay, so in normal, we'd have her cover the left eye as well, test the same thing, and then do both eyes at the same time. For time, we're just going to do one eye at a time. But a normal indication that nerve was intact is 14 out of 14, which we would expect at this point. From then, we would do the corneal light reflex. So I'm going to have her stare straight ahead, and I'm going to shine the light. We're looking for the alignment that's parallel of those axes of the eyes. And so we're going to make sure that that light is hitting the cornea on the same spot on each eye, and that's a normal finding. We need to do a further assessment if the lactating cornea at different places, but this is a normal assessment. And then to test the extraocular muscles, those are cranial nerves 3, 4, and 6, we're going to do the cardinal test. And so I'm going to stand across from my patient. I'm just going to have her keep her head straight, but she's just going to follow my finger with her eyes only. So as I do this, I'm just noting that her eyes are moving together, that one's not lagging, there's no nystagmus. So that also lets you know that those nerves are intact. Another way to do it is the confrontational test. We're both going to cover an eye, and then she's going to let me know, she's going to be looking at me and lets me know when she first sees us in the periphery for the first time. No. So I would compare her with what I'm seeing as well, and we would test the other eye, come from the other angle, and I saw at the same time she did. That also lets you know that those nerves are intact as well. So now we're just going to observe the eye. We're just making sure that her eyeballs aren't sunken in, they're not protruding. There's an even distribution of her eyelashes. Again, the alignment is symmetrical. And so as we move on, we're going to go to those deeper structures. And so we'll look at the conjunctiva first. I'm just going to pull it down, have her look up. Just noticing that it's pink, it looks moisturized. There's no inflammation, anything like that. We're noting the sclera. We can just see that it's that china white that we want to see. It doesn't look irritated. Again, a normal finding. You'd be checking both sides of this as well. Of course, you want everything to be symmetrical. We're going to look at the cornea. So I'll shine the light across. And we're just noting that that cornea is clear, it's smooth. We don't want to see any cloudiness. We're noticing that the iris is round, flat, and that the color is even, and then the pupils are equal in size, equal in alignment. It'd be about 3 to 5 millimeters, and you would want to do a further evaluation if those pupils were different sizes, but these are all normal findings at this point. While we're at the pupils, we're going to assess PERLA, which is the pupils are equally round, reactive to light and accommodation. So to do the pupillary light reflex, I'm going to have my patient stare forward, and I'm going to shine a light across. As I do that, I should note that the pupil constricts. The other pupil should do it simultaneously, but this is a normal finding to have the pupil constrict. You see it right there. And then to test accommodation, we would have the patient stare straight ahead into a distant object. And I'm going to bring an object a little closer, but I'm not going to have her look at it yet. So I see in the distance, the eyes or the pupils are dilated, and then switch your gaze to the pen. And then we notice that the pupils then converge and constrict, and that's a good finding. That's what we want to be able to see. So moving on to the ears, we're just observing the ears first, just noting that they're symmetrical bilaterally, noting the alignment of the ears, that the skin color is consistent with the rest of the body. And first we're just going to observe. And so we're noticing that the auditory meatus, there's no swelling, redness, it's clear is what we want to see. And then we want to test that nerve, the 8th cranial nerve. First, we want to pull on the auricle and the tragus, just make sure there's no tenderness there. So I'm going to ask, tenderness on either one? No? Okay. So to test that cranial nerve, I'm going to occlude one ear and then whisper 3 random letters in the next ear. And I'm going to have her repeat them back to me. We're going to do the same thing on the other side. A normal finding is about 3 out of 6. Would be considered normal. So if I occlude this ear, I'm going to whisper 3 random things. A, D, B.
A, D, B.
Mm-hmm. Same thing on this side. 3, 4, 5.
3, 4, 5.
Okay. So that's passing. Those are all normal findings. Next, we'll move on to the nose. Again, we're just looking that the nose is midline, is proportional to the rest of the body, doesn't appear to be inflamed at all. And so now we're going to check the patency. So I'm going to have my patient occlude one nostril and have her inhale, and then same thing in the other. This just allows us to compare one with the other, lets us know that there's no obstructions. And then now I'm just going to look at that, the meatus, and just check that everything looks okay. We're looking for any deviations in the septum, any swelling, bleeding, irritation, which we don't see in the nasal. It seems pink, it seems moisturized, which is all things we want to see. So moving on to the mouth, we're going to look at the lips. We're just noting that it's pink, it's not too dry, it looks moisturized. And then we're going to go ahead and move on to the teeth. At this point, we're just noting that the teeth are just in line. You would check the alignment, ask about any toothaches at this point, look at the alignment with the jaw as well. The alignment with the jaw as well. Just noting anything abnormal, any missing teeth, any cracks, anything like that. Then we can move on to the gums. As we observe the gums, we're just looking, making sure that they're not bleeding, anything like that. We can check the buccal mucosa as well. We're just gonna go ahead and look, just making sure that there's no sores. It's all pink and moisturized, which are all normal findings. So we're gonna go ahead and look at the tongue. So just gonna have her stick it out a little. Again, no sores, looks pink, everything's good. And then to test cranial nerve 12, we're gonna have her say light, tight, dynamite. We just want it to be clear, concise, accurate. So
Light, tight, dynamite.
just let you know that that cranial nerve is intact, which is of course a normal finding. And then we're gonna assess the uvula. And so first we're just gonna observe first, just noting that it is midline. And then to test the uvula, this would help us test cranial nerve 9 and 10. So I'm gonna press down and have the patient say, ah, just noting movement with the uvula when I do this. Also noting a gag reflex at this point too. We did see movement of the uvula when we heard sound, which indicates that those nerves are intact. At this point as well, we would look to see if we see any tonsils. None are seen here, but if we were to see them at this point, we would grade them as a +1. So we'll move on to the neck portion. So at this point, we're just going to feel for those lymph nodes. They should just be movable, non-tender, very discreet. So we're going to go through those first. So we have the preauricular, postauricular, occipital, submental, submandibular, jugulogastric, superficial cervical, deep cervical, posterior cervical, and then for the supraclavicular, if you want to have your patient hunch, it's a little easier to feel. So we didn't feel anything tender, nothing that was immovable or firm, so these are normal findings. So we're going to check the neck movement. So I'm going to have my patient go through a series of exercises. We're just going to make sure that she doesn't have any tenderness with this and that there's no limitation in movement. So if we look down, back up, ear to shoulder, yep, other side, and then rotation. Good, just noting that she doesn't have any tenderness again, lets us know there's good range of motion. Then to test the muscle strength, I'm going to place my shoulders on her, or my hands on her shoulders, and have her raise up. Good. Exactly what we want to see at that point, just let you know that that cranial nerve 11 is intact at this point. Oh, and so then we'll go ahead and look at the thyroid. So first I just like to see if they can bend back their head a little and then just swallow it, just to kind of observe it. Okay, and so to test the thyroid at this point, I'm going to have my patient look to the right, just to kind of relax those muscles. I'm going to try to place my finger in between the trachea and that sternocleidomastoid muscle and kind of displace the trachea and have my patient swallow. So the finding that we're looking for is that we didn't find any palpable nodules. Typically the thyroid is not palpable. If it is enlarged, then it is. At that point you would want to auscultate the thyroid, so that's not a normal finding. See, neck. Okay. So while we're back here already, we can go ahead and do the lungs and thorax. And so first I'm just going to observe. I know that the spine is in alignment, is straight. I can note that the scapula are both in an even plane. When I come to the front, I know that she has those symmetrical on both sides, that the ribs have that vertical sloping horizontal, or the vertical sloping look, which also lets us indicate that that AP to transverse ratio is 1:2, which is what we want to see. That's a normal finding. If it was 1:1, the ribs would be more horizontal and she would look like she was kept inhalation in, and that's a sign of, that's barrel chest, which would be a sign of emphysema or CPOD. So everything looks symmetrical right now. We've already assessed the skin color, skin tone, temperature earlier in the assessment. So when I have my patient here, I'm actually going to have you turn around so they can see. So I'm going to check for the expansion. So I'm going to put my thumbs right on T9 or T10, and I'm going to have my patient take a deep breath. As she's inhaling, we should see that my fingers go out symmetrically. So we'll try that first. Take a deep breath. And we see that both of them go out. I'm gonna turn back around. Both of them go out together, which is what we want to see. If there's a lag in one over the other, then that'll let you know that that side, the lag side, has the affected area. So then at this point, we're going to auscultate, and we're listening for very specific breath sounds at this point. The posterior aspect has the bronchiovesicular sounds and the vesicular sounds. And so with the bronchiovesicular sounds, that's kind of right in between the scapulas where you'll best hear those. So I'm going to have my patient take a deep breath. You're noting the important thing is to check both sides, just to make sure that it sounds simultaneous or that it's symmetric on both sides. And then those vesicular sounds are those periphery lung sounds. Okay. One more. Okay. All right. So again, all good findings. And then we're going to do the front or the anterior aspect for the lung field. And so we've already assessed the color, temperature, we've already assessed the symmetry of the ribs, that AP to transverse ratio that we want, and we can do breath sounds on this aspect as well. So we've already talked about the bronchiovesicular. You have those in the front as well, and that's by the sternum in between the first and second intercostal spaces, whereas those vesicular sounds are more out here. Again, those are those peripheral lung sounds. The anterior portion also has these bronchial sounds. These are more of those high-pitched sounds, and those are near the trachea and larynx, so we can listen for those. So for this one, I'm just going to have my patient breathe out through their mouth a little deeper than they normally would, and we'll listen for those. Okay, which are all normal findings. You can tell at that point that those sounds all sound a little different, but the thing you're noting is the symmetry of both sides. Right. So then we'll move on to the neck and heart. So to start, we're gonna first palpate that carotid artery. So you just want to do one at a time so you don't occlude that blood flow. So I'm gonna palpate one, and you're just noting the pulse. And it's super palpable here. We would grade that as a +2, but you're just noting that you can feel that upflow. And again, comparing one side to the other. At this point, we just want to auscultate for bruits at the carotid. So we'll use the belt, the stethoscope this time. And I'm going to have my patient take a deep breath and then exhale. At that point, she's exhaling, she's going to hold her breath. And I'm going to listen for the bruits in 3 places. We're having her hold her breath so we don't confuse these sounds with the breath sounds. So the 3 places that we're going to listen for are the angle of the jaw, midclavicular, and then the base of the neck. So I'm going to have my patient take a deep breath, exhale, and then just hold it. Okay, and no sounds were heard, which is a normal finding. Okay, and then we're going to do check for jugular vein distension. So I'm actually going to have my patient come lay down here. You want them to be at a 30-degree angle. And I'm going to stand at the right. I'm going to have her turn her head. And the external and internal jugular vein aren't palpable, but if you use a light source, you can kind of see the shadow of it a little better. We can see here that external jugular vein along that sternocleidomastoid muscle. If you look closely on the light, you can see the pulsations of the internal jugular vein. This helps us assess the central venous pressure. So these are normal findings, and if we have our patient sit back up, we see that that distension goes away, which again is a normal finding. If you want to have a seat back in the chair. And then we're going to auscultate. And so we're listening to the heart sounds at this point. So first we're going to use those 5 normal spots. So we have the aortic is the first one in that right second intercostal space, pulmonx in that left second intercostal space, Erb's point, which you won't hear sound at, the 4th intercostal space, kind of in that lower sternal border for that tricuspid valve, and then the 5th intercostal space, which is that mitral valve. And so at this point, as we go across, you can hear it's a little bit louder at the base of the heart, which is actually at top, and that's where you'll hear S2. That's where S2 is heard the best at, whereas S1 is heard best at the apex of the heart, which is actually at the bottom. So we'll go through and we're just going to have her take a deep breath. We want to listen for both inspiration and expiration. Okay. And then at this point,
Just go back to that.
okay. So at this point, while we're at the apex, we're at that apical pulse area as well, which is the point of maximal impulse. So while we're here, you can go ahead and get that rate and heart, or that the rate and rhythm of the heart. You just want to listen for about 30 seconds and then times it by 2. If you hear anything irregular, or if it's out of those normal ranges, then you want to listen for a full 60 seconds. So we'll go ahead and listen there. Okay. So I got 68, which is in the normal range. We wouldn't need to do that any longer. Sure. Oh, so we can assess for murmurs now. Also, side note, when you're doing the apical pulse, that should be the same using that S1 point at the apex. It's also the same as that carotid pulse. So if you want to compare them, you can auscultate at the same time, feeling the pulsation of the carotid artery. You can compare those as well, which is also another accurate way to find it. So we're going to go through again, listening to those same spots, but with the bell, the stethoscope. This way we're just listening for any murmurs. It picks up those low-pitched sounds. Again, we don't typically want to hear any, so we'll listen to those same areas. Okay, again, no sounds were heard, which is good, that's appropriate. Now we're going to have our patient come lay down, and they're going to lay on their left side, and we're going to see if we can hear any of those extra heart sounds. We're listening for S3 and S4 right now, which indicates those diastolic filling sounds. Typically these sounds are not heard, but if they are, they're not always pathologic, but when they are, it kind of indicates that there's a fluid overload, which is indicative of heart failure. So we're going to have them laying on their left side. We're going back to that apex and listening for any extra heart sounds. Okay. Which again, none were heard, which is a normal finding. So if you want to come back in the chair, now we're going to assess for murmurs at the base. So we're going to use the diaphragm actually on this one. So we're going to have our patient lean forward a little bit, and then again, they're going to take a deep breath, exhale. When they're exhaling, we want them to hold their breath at that point. And we're going to be at that aortic and pulmonic area, seeing if any murmurs are heard at that point. So take a deep breath, and then exhale. Okay, hold breath. Okay, and no murmurs were heard at that point, which is good. Of course, is a good finding. So then we are going to move on to the abdomen. So I'm going to have you come lay back down. So first with the abdomen, we're just going to assess. We're just looking at the contour, and we've already noted the symmetry with the color and temperature, and it helps a little bit if you just kind of get at eye level. You're just knowing that the contour again is flat, that there's no bulges or masses on either side when comparing one side to the other, always noting the symmetry. So first we're going to auscultate. So we want to start in that lower right quadrant. That's where you'll typically hear sounds, but you should hear sounds all the way through. So we're going to go through each, just have our patient breathe normally, and we're just going to go through each of those 4 quadrants in a clockwise motion. Again, with this, you should be hearing kind of those high-pitched gurgling sounds This point as well, we're going to auscultate with the bell, listening for any bruits. And we're going to go along those arteries, so the abdominal aorta, iliac artery, renal artery. We don't typically want to hear anything. Okay, so no sounds were present, which is a good finding. So then at this point, we're going to percuss. And so I'm just going to tap right on my finger, and again, we're going to go kind of in a zigzag, clockwise movement around. So since we are at the stomach and the intestines, the dominant sound at this point should be tympany. If we go over the liver or spleen at all, we'll hear more of a dull sound, which is normal when you go over an organ like that. But again, we did hear that tympany sound that dominated over the intestines and stomach. Then at this point, we're going to palpate. So first we'll do light palpation. This just kind of gives us an overall impression. You're just going to go about a centimeter using your whole hand, and you're just kind of pressing in each of the quadrants. And you can go to deep palpation using both hands. This one you go a little deeper, about 5 to 8 centimeters. And then at this point, you're looking to see if they're guarding at all, if they have any tenderness. That lets you know that some of their organs may be enlarged. You actually might be able to feel some of those enlarged organs as well. And we'll just go a little deeper in all 4 quadrants. Okay, so there's no guarding or tenderness, which is a good sign at this point. I think that's it for the abdomen. So we're going to palpate the liver as well. So when we do this, I'm going to have my hand in the midline or parallel midline, and then I'm going to have my patient breathe normally. Each time that they exhale, I'm going to move my finger up another inch or 2. So typically you won't feel anything, but sometimes on inspiration you might be able to feel that border of the liver. We don't feel anything now, which is still a normal finding. So then we'll get to the spleen. So we're going to put that left hand across their body just to kind of support them a little bit. And again, we're going to go under that costal margin on their left side. You want to go more of an angle towards the axle a little bit. And then again, just listen or feel for them to deep breathe, and just note that if you feel anything, okay, just take a couple of deep breaths. And again, you shouldn't feel anything. Unless the spleen was enlarged, then you would. Normal findings would just be that you didn't feel anything firm while palpating for the liver or the spleen, which we found here. So these are normal findings. So then we have the kidneys. So for the kidneys, we're kind of use that duckbill hand movement, and you have to press much deeper to palpate the kidneys. So you're going to go on that flank and just press down. And you're just going to have the person take another deep breath. These typically aren't palpable either, but you just want to make sure that there's no change during inspiration and expiration. Then we go on the left side, just note that that kidney might be a little higher, about a centimeter higher. Again, support, and then go back up. Go a little deeper, and just note that there's no change on inspiration or expiration. So now I'm going to assess the patient's lower legs. So we've already assessed the color and the temperature in the assessment earlier, noting there were no lesions that we need to be concerned about. The color was symmetric on both sides, temperature was symmetric on both sides, and it's all consistent. We already noted that there was no edema. We checked for pitting edema earlier, and none was noted. But now we can check for pulses. So we can do this at the same time. Just going to have the patient relax. So we have the posterior tibialis, and that one's on the, you can test both at the same time, and that's in between the medial malleolus and the Achilles. So if you just place both hands, and these ones are palpable, so we would rate these probably a +1, and you just want to make sure that it's equal bilaterally on both sides. And then the next pulse we can feel is the dorsalis pediis. So this one uses a very light touch. I typically just do one hand at a time since it's you need a lot of concentration to feel this one. You typically feel it kind of lateral and parallel to that extensor tendon on the big toe, and again, it's a really light touch, but it is palpable, and you can actually feel them right now. So I would rate that one as a +1 as well. but it is symmetric on both sides, which is what you're looking for. So these are all normal findings. Okay. All right, and then we'll move on to the musculoskeletal. So we'll stand up for this one for now. Let's see. Okay, so I'll stand here. So first, I'm just gonna go through some range of motion and strength activities with the patient, just to make sure that, again, they don't have any limitation with movement. So first, we'll move on to the shoulder. So I just want to see that they can do the same movements as I do, and just let us know if there's any limitation up and back. So as she's doing this, I can also feel while they're doing it, just to make sure they don't have any crepitation. So if you want to do a couple of those, you're just making sure that there's no popping, there's no limitations in the movements, doesn't know any tenderness, and just knowing that the movements are smooth and controlled, which are all normal findings. So to test the strength, which we did earlier, if you press down, raise your shoulders up, again, just noting that it's equal bilaterally. We can do another one, so I'm going to resist you if you just raise your hands up. Yep, and we'll go to the side as well. Good. Again, just noting that it's equal bilaterally. That's really what you're looking at. Then we can do the elbows. So with the elbows, we just want to see that you can flex, extend, and then have pronation and supination. So to test that, I can, see. Okay, and you're going to go up, and I'll try to resist you. Yep, same thing. Okay, good. And then we can kind of do the wrist and fingers together. We just want to see that they can go down, up. With the hands, we want to see this, and then that and that. Okay, good. And then we're going to place our hand here, and then if you just want to raise your fingers up, and I'm just going to try. Perfect. Same thing. Okay. All right, again, it's all equal. You just want to make sure it's equal on both sides and that one's not significantly weaker than the other. So then we'll move on to the hips. I'll actually have you lay, right here. Have you lay back down.
Lay down?
Mm-hmm. So to test the hips, we might just be able to do one at a time. Normally, of course, you would check both. So we'll check all the movements of the hip. So we're just going to go up first, straight, yep, down. We'll come out to the side here, and then bend here, and then go in, and external, internal. Again, you're noting both sides on this one. You can come back up. And then for the knees. So obviously they're an extension now. You can test flexion just by having them, yep. And then another way that to test it is have them bend both knees. This way you can kind of compare one and the other. And then if you want to have a seat for this one, so then we can kind of do the foot and ankle. I have to move down. So for the foot and ankle, first, just a little bit. We're just going to have her, we got plantar flexion, dorsiflexion, and then inversion and eversion. Yep. And then same thing with strength. If you want to do yep. And I'm just going to resist. Yep.
I always mess up.
I know. And then perfect. They're the same bilaterally, which is really what you're looking for. Okay. Then we can check range of motion on the spine. So if you want to stand back up again. So for the spine, we just want to go forward, extend, rotation to both sides, and then lateral flexion to both sides. Perfect. So while we're up, we can go ahead and do some of the cerebral function test. So for the upper body, we have the finger to nose test. So you might need to sit down for this one, so you have to close your eyes, just whatever you're comfortable with. So we're going to have the patient close their eyes, and they're going to slowly just go from finger to nose, and then they're slowly going to go as fast as they can. So go ahead and start, and then start to pick up the speed. Okay, good. So we're just looking that it's accurate, that's just smooth and controlled movement. Another one that can keep their eyes open, you're going to touch your finger to my finger. Again, you're just looking that it's accurate. Okay, so that's good. And then for the, another one for the upper extremities is the rapid hand movement. So the patient's going to start going like this, and they're slowly going to pick up their speed and go as fast as they can. Again, you're just noting, that's good. You're just noting that the movements are concise, accurate, and it's just controlled. And then the cerebral function for the upper body. So if you want to stand back up, and then on both feet, first we're going to have you just go from ankle to heel to shin and go all the way down. Yep, same thing with the other one. Perfect. So you're noting the balance, again, the accuracy, and that it's symmetric on both sides. And then for the Ronberg test, so I'm going to have you close your eyes, you don't have to do it yet, and then just stand there. All you have to do is stand there. So a positive sign for this test would be the patient losing balance. If you want to go ahead and close your eyes. So normally this would be for 20 seconds. As you can see, you expect your patient to be able to control their balance, control their posture. So this is an expected finding. You can open. So then we'll go ahead and do some of the neurological tests. So you can kind of see it if you like. So we have a cotton ball. We're just touching that, or using the light sensations. And we'll use both the face, we can use the hands, the legs, as well as the feet. So I'm going to have my patient close her eyes in a second, and I'm just lightly going to touch it on certain places of her body, and I just want her to tell me when she can feel it. We'll start with the face, but you don't want to go too uniform where they expect it. So that's where we're going to have them close their eyes, so kind of mix it up. But we'll start with the face, so you just let me know when you can feel it. Okay, and so we'll go on to the other parts, but you do want to make sure that you're testing both sides. Don't just test the right side. You want to make sure that you're always testing both sides. So then we'll use the hands. So again, close your eyes. Let me know. Okay, we'll go ahead and do the legs. So I'll use your thighs. Close your eyes. Okay, and then again, we'll do the feet as well. Okay. Okay. So then lastly, we have the reflexes. And so again, normally you would test both sides. You want to see if it is symmetric bilaterally, but just for time right now, we're just going to do one side. So first we have the brachial. So I'm going to support her arm. Yeah, you can just rest it on mine. I'm going to hit my own thumb. And we notice that she does have that impulse. You see that her reflex was contraction, or flexion, which was what you wanted to see. We'd grade that one as well. +2 is normal, which is what I would have graded that one. So for the triceps, I'm just going to have them completely relax her arm. Let's have it completely dead. And I'm going to hit directly on that tricep. There we go, and you can see that one there as well. Here's the brachioradialis one. You're just going to go about 2 or 3 centimeters above that styloid process. You can just relax there. And there, you can see that one as well. Rate that one as a +2 as well. And then we will do the patella. Just go right in that area. Use the flat part at this point. You can see that one a little bit. We can go ahead and do this one as well. You can see that one as well. And then we can use the Achilles as well. This is actually easier with the patient lying down. So if you want to go ahead and lie down, and then if you want to flex this up a little bit, yeah, perfect. And then right there. So this one is going to be dorsiflex. We'll try to hit that one a little bit. And you can see that that reflex was to plantar flex. So I think that is the conclusion of the health assessment. Thank you.